That was funny.
Hello, everyone. Welcome to another Monday's specialty. We are dedicating now for our dear friend Rafael Medina, and we really miss him. I today was thinking that I was going to ask his help for this section today, but we don't have him anymore. So I want to dedicate it for him. And it's been 2 weeks, and it's been really hard, but we love you, my friend, and we continue doing your amazing job here on CPS Solvers. And we have the pleasure to have two doctors, Dr. Gallo and Dr. Sanborn from Mayo Clinic. And I want them to introduce each other and tell us a good story how they met each other.
Do I go first or do you go first? I can go first, it's fine.
Go for it.
I'm Alice Gallo. I am an intensivist at Mayo Clinic in Rochester, Minnesota, and I'm also one of the APDs for the internal medicine residency program here in Rochester at Mayo Clinic. And thank you, Deborah, for saying the kind words you said about Rafa. He will always be with us. It is very sad. It's surreal because it was the same thing when I was logging in today. I'm like, wait a minute. No, but he's always with us. And I actually wore my love first t-shirt today for him. So Dave and I, Dr. Sanborn and I met when he was an intern 5 years ago. 5 years ago, yep. When he was an intern. Yep. And he arrived in the ICU, and I feel like he was like, okay, we're best friends forever, and instantly. And I don't remember if you already wanted to do Pulm Crit, but I do take a little bit of credit for you wanting to do Pulm Crit, because I remember our conversation and me saying like, this is the best job in the world, like if I was like a crazy person. But I do take a little bit of credit. And I remember the first day we met, I remember him coming in the unit. I remember saying hi, and I remember my spiel that I give every week when I start the team is like, this is the best job in the world. We get to take care of the sickest people. So I remember that.
100%. I remember it like it was yesterday. And no, I didn't know. So guys, I'm David Sanborn. I'm one of the first year Pulm Crit fellows at Mayo. I did residency here and I did a chief year here. So I've been here a while. I remember it like yesterday. I was not thinking pulmonary critical care. This is a warning that if any of you do a rotation at Mayo and you happen to work with Alice Gallo, you will leave doing pulmonary critical care because it's hard not to after you've worked with her. And so I was going to do general medicine. I wanted to be a hospitalist. And then I went through a long period of like going through every specialty. I wanted to be a nephrologist. I wanted to do cardiology. I didn't know I wanted to do everything. But then I was like, wait a minute, Pulm Crit, I get to do everything, and I get to like do procedures and put needles and things and do fun things in the ICU all the time. And so then it was like, all right, she convinced me she was right. It only took me 3 years to realize she was right, but she was right. And so here I am. And so I'm interested in all things Pulm Crit, and particularly lung transplant is what I'm interested in as a career for me. And I think they said like, let's include a favorite memory. And I have an easy favorite memory of you is when you brought me the, I'm going to mispronounce it, bellinos, those coconut.
Oh, beijinho, beijinho, yeah. I made Dr. Sanborn beijinho or branquinhos if we have anyone from South Brazil. Made him like the whole thing, and him and his fiance were like hooked.
Oh, it was like immediate. We ate the whole thing in one night, and then now we have a nice gift food exchange that we have. So it's a good tradition we keep alive.
We do keep alive. Yeah. We're very good friends. And again, I'm very, very thankful for the CP Solvers, for the platform. And as an educator, it gives me, like, there's very few things as an educator that give me more pleasure than being able to sponsor colleagues that are junior to me. So Dr. Sanborn, you're witnessing like the bright future of lung transplant, and just write his name down. And I do want a full disclosure. I have no idea what the case he has today.
Nope.
And I make a point of not knowing for two reasons. One, because it's fun. And two, because I try to role model what I preach. And I'm a strong believer of vulnerability. And I'm a strong believer that it's okay not to know things. And I'm also a strong believer that it's totally okay to be uncertain about something. So those are my three reasons for not wanting to know. And he's like, do you want a hint? I'm like, absolutely not. I don't, no.
Yeah, let the record state, I tried to give her a hint. She said no. So
yeah. Let's do it. I'm not afraid of making a fool of myself. Let's do this.
I'll get out of here.
I love it. So I think, yeah, we can start. If you can tell us, Dr. Sanborn, the chief complaint.
Perfect. So this is good. This is a good layout for me. So chief complaint is dyspnea. So this is a 33-year-old woman who is pretty healthy. She has a history of migraine headaches and came in via the emergency department for dyspnea that had been progressive over a few months' time and really no other associated symptoms. That was really the main thing that brought her in.
Can I ask a question?
Absolutely, you can.
She came to the ED. Did she bring herself to the ED? Did she call EMS? What was tell us a little bit more about like her presentation.
So she was brought in she did not drive herself. A family member brought her in. She was too ill to bring herself in. And so this was a kind of gradual decline, but finally reached a point of, we can't take care of you at home anymore. We need you to go get help. And so she was quite ill.
But her concern was short of breath.
Yep, she was finding that so like I said, pretty healthy young woman. She normal activities, lifestyle prior to feeling ill over the preceding few months. So the point that really brought it was she couldn't even walk to like the bathroom without getting winded. So significant dyspnea with exertion. Did also have some dyspnea with rest at times. So that was really what pushed her, was she couldn't function at home anymore.
Okay.
Yep.
So pretty healthy, just migraine headaches, dyspnea that is pretty broad, right?
Very broad.
But things like my next question for you already said a few months, but a few things that are associated. So any cough.
Little bit of a dry cough every once in a while, especially when she gets really short of breath, she'll notice a dry cough.
Okay. Any time of the day when the cough is worse?
No, any time of the day.
Okay. The reason I'm asking this is just again, and I hope it's okay with the CP Silvers team that I say my rationale out loud so I don't forget. The reason why I'm asking about time of the day cough is things like post-nasal drainage and things like that usually happen more at night. And cough that is related to airway usually is more related to exertion. That's why I'm asking if there's anything associated with cough. Anything for heartburn or GERD?
Really, no. No symptoms like that. The thing that I remember most from this case was just pretty much all of my review of systems was like one after another, nothing. So no GERD.
Okay. How about weakness?
A little bit of weakness overall, that as this really started to accelerate in the last week or two, she felt weak. So you can't do anything. So she feels like she's losing muscle tone. She's lost weight.
That's what I'm gonna ask. Okay. Unintentional weight loss too?
Yep.
Okay. And so unintentional weight loss kind of got progressively weaker, dyspnea for several months. Does she have a history of tobacco abuse disorder by any chance?
No tobacco abuse and no vaping, no e-cigarettes, nothing.
Thank you for reading my mind. That was gonna be my next question. How about any other drugs like alcohol or cocaine, something like that?
No, just social alcohol use, but no other drugs, nothing.
Okay. And what could she do before she started feeling short of breath? What was she able to do?
Oh, she was like I said, pretty active. So she would like routinely walk. She I think that she worked as a clerk in a store. So she was up and like stocking things in a store, lifting like semi, light to moderate weight objects without any problems. And then actually had to quit working over the couple of months leading up to this because she was starting to get so dyspneic at work.
Okay. Has she traveled recently outside of Minnesota? I'm assuming she's from Minnesota if we saw her here in Mayo.
No traveling, nope, but
Okay.
is from Minnesota. Actually, really has not traveled much at all. Yeah.
Okay. Okay. Does she have any pets?
No pets at home. No.
Very important for those of you actually taking step 2 and just for good pulmonary and internal medicine. We are here in Minnesota in an area of histo and blasto, and don't forget that dogs can give humans blasto. So that's why I'm asking. Does she live with anyone who is sick? Could this be like some kind of like smoldering infection?
No one's sick at home. Nope, everybody feels good at home. No one's been sick in the last couple months.
Okay. And she's not pregnant, I'm assuming?
She's not pregnant. She had a test and it was negative.
Okay. Just making sure also, because it could be like, oh yeah, she's in her 3rd trimester of pregnancy, and then I would expect her to be short of breath. Not to the point that she can't work, but I would expect her to be short of breath.
Sure.
How is she sleeping? Can she sleep?
Ooh, good question. She can sleep. She does say that she has still dyspnea. She'll wake up occasionally with dyspnea, but she is able to sleep and feels pretty well rested throughout the day.
Okay. And the reason why I'm asking this is because untreated sleep apnea can cause daytime dyspnea. So I just want to make sure we talk about that too. And let me see what else any chest pain?
No chest pain.
Okay. So sounds like a young woman, previously healthy, progressive dyspnea. Things that are worrying me a little right now is this dry cough and unintentional weight loss immediately at her age. Things like cancer come to my mind. And obviously, we always have to think about some kind of like smoldering infections, like fungal infections and atypical mycobacteria, which is more common in Minnesota than TB. But again, TB is everywhere. So those are the things that I'm thinking about right now. Does she have any fevers, night sweats?
So no constitutional symptoms, really no infectious symptoms at all. I know, I feel like I'm answering no to everything.
That's
Sorry.
all right. No, that's good. I love it.
No, this milieu, no.
And for her migraine, is she taking any meds?
No, she is not. I think she had a triptan as like a PRN that she used, but it was pretty rarely.
Okay. And most of the migraine meds won't cause shortness of breath, but just want to make sure.
Yep.
Don't forget that sometimes beta blockers can lower people's heart rate to a point that the brain perceives as a dyspnea. So that's why I'm asking, but she's not on beta blocker, sounds like. Any concern on the family that anyone had any lung problems or any autoimmune problems?
Very good question. The answer is no, but that was a question that I asked. Yes.
Okay. And sounds like nothing recently in terms of illnesses, no sick contacts, no one sick at home. Okay, I am ready for physical exam then.
All right.
Where did you see her? ED or clinic?
Clinic.
Okay.
I saw her clinic, so I'm recreating the ED, but I've read every note in this patient's chart because just a great case. And so, so I'll give you the exam that I saw in clinics. Okay. By the time that she came to see me in clinic, so I'll go in order here. So temperature, 37. Heart rate was 90. Blood pressure, I'll just keep it easy, 120/80. Respiratory rate was 20, and SpO2 was 92% on 4 liters by nasal cannula.
Before we go on, I just thought about 2 things. Again, not everything that causes dyspnea comes from the lungs. I know you have CTs, so I'm assuming it's from the lungs, but I just want to make sure we talk about this. We are sure that there is no thyroid disease in the family.
There is no thyroid disease. Nope.
Okay.
Family's otherwise pretty healthy.
Okay. And and I had another question that I was gonna ask. Oh, I already asked about chest pain and something else. No, I think that was it. Okay.
You ready?
Oh, she's hypoxic. Okay. Did
Uh-huh.
not see that one coming. Okay, I am ready.
Okay, so she, general exam, she just looks tired. She's not in any distress, but she looks very tired. She, ear, nose, throat, really nothing there that was that exciting, to be honest with you. Heart sounds normal, no murmurs, gallops, rubs. Respiratory, so she had distant breath sounds throughout, just distant breath sounds throughout. And no wheezing, no crackles, very diminished to inaudible at the bases bilaterally.
Did you have an ultrasound machine at that time?
I did have an ultrasound machine.
Ooh, what did your chest ultrasound show?
I found bilateral, simple appearing pleural effusions.
Wait a minute. Okay, okay, we're getting to extremities, but did she have lower extremity edema?
No, she did not have lower extremity edema at all.
And when you said she woke up in the middle of the night, was it orthopnea or it was just like cannot breathe?
Just cannot breathe. It was really orthopnea. Yeah. And really no history that made me think cardiac primary, to be honest with you.
Okay.
No PND, no orthopnea. Yeah.
And this 92%, nothing for orthodeoxia, like it was not different sitting up and laying down.
Nope, no difference between the two.
The reason why I'm asking is she's a woman, she's 33 years old. She's also like the demographics for primary pulmonary hypertension. So that's why I'm asking. Okay. Okay.
Belly soft, nothing, non-tender to palpation, neuro equal, all extremities, cranial nerves intact, extremities and skin, really nothing. Looked well perfused, no rashes, no cuts, bumps, or bruises.
Okay.
So really the only thing was what I heard from listening to the lungs and then the ultrasound. I should have mentioned, so for the down to imaging again, the pleural effusions, I would call them, they were moderate. They were probably like 300 to 500 cc's each, if I had to guess.
Okay. And okay, so progressive shortness of breath with bilateral pleural effusions, dry cough, intentional weight loss. Obviously, as someone who staffs the pleural clinic, I just want to get a sample of this fluid before anything. But for educational purposes, do we have any labs for her, and do we have an EKG for her?
Dr. Gallo, we have a question about this hypoxemia. How you approach this hypoxemia that the patient is presenting?
Right now she's hypoxic and she's 4 liters nasal cannula. If I know patients have large pleural effusions, even the large pleural effusions causing a little bit of a restrictive physiology can make them hypoxic. I don't know what's going on her parenchyma. Again, if she has a parenchymal disease, any of the things I said before, any type of malignancy, any type of slow growing infection, and any reason for someone to have pleural effusions, if it's heart related, if it's lung related, if it's pleural related, can cause hypoxemia. So that's why I'm asking about her heart. I would love to see an EKG. I would love to see an echo. And again, we're going stepwise approach. Obviously, I would send also her for a CT of the chest, and I would tap those pleural effusions and send them for Lights criteria. So I'm ready for labs.
What I'm like, so I'm thinking, okay, so hematology, so white blood cell hemoglobin, all of that was within normal limits. So white count was 5, hemoglobin was 14, platelets were 200.
Wow, okay. So that already excludes anemia as a cause for her shortness of breath and anything going on like bone marrow related that could be causing shortness of breath and plus minus some kind of thoracic abnormality. And by
Yep.
thoracic, I mean intrathoracic, not well.
She had, what I'll tell you is some notable other labs. So you wanted the effusion study. So it was, let's see, I should have written the exact values down. So LDH we'll say was 300 and protein was 6. And yeah, so they were high.
That's pleural fluid.
Yep, that's pleural fluid.
Okay, so it's an exudative pleural fluid, and I saw something popping up. I didn't see from whom, saying that a young patient with bilateral pleural effusions could not be hypoxemic. Yes, they could. They can. They do. They present hypoxemic to us. Yes.
Mhm.
Sorry. Okay.
Yep. And so exudative effusion, totally agree. I'll tell you her chemistry stuff. Really, I'll be honest with you, was not that revealing. I'm going through her labs to see if I can find anything.
Do you have a description of the fluid? Was it chylous that we need to think more lymphoma? Was it something like with thoracic duct obstruction? Did she have any trauma? Oh, I should have asked that. Did she have any trauma with these bilateral pleural effusions to the chest?
No trauma. No trauma to the chest. Good question. But no, it was actually, the description for the tap was actually pretty bland. They described it as just yellow, but didn't describe it as like milky or anything like that.
Okay.
You believe that they had a triglyceride level when she first came in, and I want to say it was like 30. It was well below 120.
Okay.
So it didn't really fit with that. Kind of the follow-up studies, they did some additional. The pH was normal for the pleural fluid. The glucose was normal for the pleural fluid. So it was pretty bland, just exudative, very clearly exudative.
Yeah, clearly exudative. Okay. And did we do cytology?
Cytology, all they said was chronic inflammation, no evidence for malignancy.
Okay. Very interesting. Did we send for cultures?
We did send for cultures. They were negative. And gram stain was negative as well.
Did we do AFB smear?
I at one point, yes. I don't know if I did initially, but yes, and it was negative ultimately.
Okay. Love this question from VJ. ADA is not something commonly done in the United States because tuberculosis is not as prevalent. We can do PCR. And so we usually do acid fast smear, and we do also PCR for tuberculosis and non-tuberculous mycobacteria. So we normally in the US, commonly we would not do ADA.
Mm-hmm.
Great question though. And I was gonna ask you something else.
Maybe I'll tell you. So like I said, the chemistry panel was really bland. I can go through them all one by one.
No, I trust you. Her TSH was normal, I'm assuming.
TSH was normal. Yep. Yep. And EKG, very normal.
Okay.
Just stone cold normal.
Okay. Before you give me her chest x-ray or CT, whatever you have, do we have by any chance some kind of confirmation that at least her EF and her RV are okay?
Yes. Well, just only on the TTE, but her EF on TTE was 60.
Okay.
And her, I think her RVSP was something like 18. It was.
Okay. Super normal. Okay. Okay. So we have a young woman with progressive dyspnea, bilateral pleural effusions, chronic hypoxemic respiratory failure on top of that. Not much for review of systems, except for the fact that she did have unintentional weight loss and does have exudative bilateral effusions that do not have a positive cytology. And okay, just making sure. And bilateral exudative pleural effusions, heart that is working. So very unlikely this is a cardiac disease and is bilateral. So very less likely that it will be less likely that it will be from the heart anyways. So I am ready for some kind of chest image. And another thing very important, if a a patient presents with pleural effusion and you will think you need a chest CT, try to tap the effusions before, so then we can see the parenchyma open, because if it is like a small cancer or beginning of cancer, it might be in the lung that is atelectatic under the effusion. So
I very stupidly, I'll give you your CT chest is what I have for you, but I should mention on the TTE, she also had a pericardial effusion.
oh,
I know.
okay. But did she have restrictive physiology?
She did not, no.
Okay.
But
Okay.
show you, so
it has to be something cellular. It has to be some kind of malignancy or some kind of like systemic infection that is causing serositis. Oh wait, we have serositis. Did she have any joint complaints?
She did not have any joint complaints, but I like this line of thought.
Okay, did we get anything for like vasculitis, anything for connective tissue disease?
So we did get no vasculitis, but ANA is strongly positive.
Okay. Oh, serositis, okay.
Double-stranded DNA is borderline positive. It was 31.7. The ANA was 10.4.
What was 10 before?
The ANA.
Okay. And how about the rest? How about the Joes,
All of the rest of it was fine. Those were the only two that were really positive.
Well, ANA is super non-specific, and double-stranded DNA being negative.
I'm sorry, double-stranded DNA, it was borderline positive. It wasn't super, it was elevated.
And she had not taken any steroids recently or anything like that?
No drugs, no steroids, nothing.
Okay. And
pictures to you. This is
and the ENA is normal?
No, ENA came back positive as well. The ENA. Yep.
There's a mixed connective tissue disease because of something. And I'm pretty sure it's her chest. Let me think. Mixed connective tissue disease is going to be something in the thymus. Maybe? No, don't know. Okay, tell me. Show me her CT. I'm ready.
All right. So I'll share my screen here, guys.
And she had no rash? She had no rash.
This was, am I good to share my screen, you guys? Hopefully that.
Yeah, you can share.
Okay, I think you have to stop sharing, whoever is sharing.
Oh, wait.
David, she had no rash, nothing on her skin, huh?
Nothing.
Oh, I'm having so much fun.
I know, this is
I want to do this every Monday. Okay, we'll do this every Monday.
Okay, you guys tell me if you can see.
She's 33 years old?
She is 33 years old, and these are the legitimate pictures from her CT. What do you see?
Terrible emphysema.
Terrible emphysema.
And with no particular lobe.
Nope.
Can we get an alpha-1?
Yes, alpha-1 antitrypsin and genetic testing were both negative.
What is the length of her telomeres?
Oh, that's a good question. I don't know that answer. I'm not sure.
Oh, we need to know that.
Yeah, I should look into that. I'm sure we have it measured somewhere, but I don't have it. I didn't write it down.
Okay. For everybody, young patients with, usually they present with pulmonary fibrosis, and usually there is a strong familial history, but short telomere syndrome is something that we have to think about. But she has severe emphysema with no particular lobe preference. And you can see what Dave is showing there, that that all her lobules are destroyed. And this is very different. And she has a little bit, can you show the honeycombing on your sagittal view? No, sorry, your coronal view on the right lung. Yeah, right there. So I hope you can see how different the honeycombing is, because the honeycombing is small cysts, kind of like several lines of small cysts, as opposed as the left upper lobe, which is classic emphysema, where the trabeculations where the trabeculations are, no, LAMs are cysts. There are no cysts there, but great thought. Where the trabeculations on the left upper lobe are completely destroyed. And the sagittal view, you can see perfect how the the lungs are all emphysema, there's traction of the vessels, and you can also see that her left, she still has a little bit of a pleural effusion that is causing atelectasis of the lung, and you can see some air bronchograms, and there are air bronchograms on the right as well. So things that make me think right now is Birt-Hogg-Dubé. That's one of the things that I think about.
Yep.
So cysts, bilateral pleural effusion, female, young. That's my main diagnosis right now is Birt-Hogg-Dubé. And it's not cystic, so not Lamb. No family history. I will still check her telomere length though, just for thoroughness. And if I'm not mistaken, Birt-Hogg-Dubé does come with a positive ANA. Don't remember if Birt-Hogg-Dubé has anything to do with double-stranded DNA, but the ENA is usually positive, and I believe is Joe positive.
I think you're right.
And Dr. Gallo, what will be your next step on this patient?
Oh, she needs some kind. Can we do? Can she get pleural biopsy?
So yes, absolutely. So she actually went for. So I'll give you that. That's actually next on my list. So
and wait, I am thinking Birt-Hogg-Dubé, so I need to do a kidney ultrasound, and I need to do a liver ultrasound as well, just to make sure we don't have anything there. And you did tell me her skin was fine though. Usually Birt-Hogg-Dubé, they have I forgot the name. See, forgot the name.
Fibrofolliculomas.
Thank you.
There you go.
Folliculomas. Very good. Appreciate you. Whoever said that. Appreciate you. But when you, and again, like if patients have folliculomas, this CT of the chest, and they have any renal findings, then the Birt-Hogg-Dubé diagnosis is basically made. Then they don't need tissue. But it sounds like you have tissue.
So we do have tissue. So she went for, let's see. Give me 1 second. Where did I put it?
Where did we do pleuroscopy?
So she did pleuroscopy.
Okay.
Yep. And oh man, I know I have it right here. Give me 1 second, guys. Okay. So pleuroscopy just showed marked bullous changes of the right lung and nodular density in the posterior parietal pleura. Biopsy was obtained and was consistent with chronic pleuritis. That's all that we got from the biopsy. It was just chronic pleuritis. And at this point, you can imagine, so like you said, you have serositis at this point. I think I saw somebody said page room. Rheumatology did get involved in this case. And that was really all that we had. I'm trying to think of other labs that we haven't discussed yet. So just because you mentioned it, Dr. Gallo, so we talked about LAM.
Yeah.
So LAM is there. So we did do testing for that. So we did do the vascular endothelial growth factor. There were specific stains that were done for LAM on her pleuroscopy biopsy. Those were not really to be consistent with that. Like I said earlier, her triglyceride count from the TAP was normal. So it didn't show anything that could fit with LAM, because sometimes that can have an elevated triglyceride count as well.
The thing is, her CT doesn't look like LAM. CT for LAM is like very well-defined cysts in the hundreds to thousands, no low predominance. This woman has emphysema and a little bit of fibrosis, so. But sure, keep talking.
So I guess now, any other information or any other points that we should try to make? Because I think your differential is a good one. So basically, when I was at this point in the diagnosis, I was trying to think like, okay, I'm pulling out my zebra cases, because this is a lady that kind of we're getting down the path of lupus or some mixed connective tissue disorder, but I don't really know of any clear association that would cause this degree of parenchymal abnormality in this person. And so I started pulling up these like Birt-Hogg-Dubé, LAM, like all of these other different things.
So histiocytosis, like all the histiocytosis can do this.
Langerhans histiocytosis, amyloid, you know, all these things.
All these things. So did we have anything on her kidneys? Is her kidney ultrasound okay?
Kidney ultrasound was okay. Liver ultrasound was also okay.
Okay. Yasmin, what you're talking about is LAM, and again, her CT does not look like LAM. And so again, with normal kidneys and no skin findings, bird hog debate is going down and histiocytosis is going up for me. I don't know that we have any parenchyma to go after.
Nope. And so if you're in the,
So then amyloid is still in the differential. So I would do a fat pad biopsy, pretty safe.
yep,
Pretty safe.
no amyloid, Congo red negative.
Then it has to be histiocytosis, and then she needs a bone marrow biopsy.
So this poor young woman had just about every test that Mayo can think of thrown at her. She had a truly extensive workup, and pretty much everything was coming back negative, other than what I told you that came back positive. So we have these borderline positive markers, ANA and double-stranded DNA. We had an exudative effusion, these obvious CT findings, and we were still sitting there scratching our head because it didn't fit neatly into one bucket.
Does it?
No. And so
I'm going out on a limb here.
Go for it.
Does she have a wood burning fireplace in her house?
Oh, a good question, but no, she does not have a wood burning fireplace.
Okay.
And I'll be honest with you, I can't wait to tell you how this. Yeah, what are you thinking? Somebody says. Someone goes, "What's that?" I had a question recently.
Wood burning fireplaces or wood burning stoves are actually one of the few things that can cause this degree of emphysema without in non-smokers.
Yep.
So that's why, like, I'm like,
totally. You've brought up like all the big differentials, I think, that were on the list.
And I'm assuming we ruled her out for all these infections I'm talking about, right?
JP was negative, sputum cultures, all the cultures from the taps, everything came back negative.
And her HIV is negative too.
HIV is negative too. Yep.
Okay, because HIV is another thing that can cause falsely positive ANA if they are really immunosuppressed.
Yep.
And TB is negative everywhere.
Yep. TB is negative everywhere. Multiple tests.
Okay, I will go for some kind of lung, but we can't remove, like, she doesn't have any lung left.
Nope. So I guess what I'll tell you is, what am I interested in? Because she ended up getting worse and worse.
And got lung transplant.
She ended up getting a lung transplant.
Okay, good for her.
Yep. Because of this issue. And so
her explanted lung, tell me what her explanted lung looked like.
Lung. And maybe I can see, let me see if I can share that. I wasn't really prepped. I can show, I won't show it. The lungs look like you would expect. The CTs were perfect images for what you expect for the lungs. Here is the pathology report from the lungs. So marked cystic and emphysematous changes, upper lobe predominant, lower lobes and right middle lobe with atelectasis, just like you saw on the CT scan. So they really saw a lot of atelectasis in the middle and lower lobes. The upper lobe predominant did have cystic changes. They were thin with mild fibrosis, but like you said, there was a lot of emphysematous changes as well. So she had both, kind of in the peripherally, she had the more cystic changes, and then central bullous emphysema. Most consistent with emphysema, all of her staining, so HMB45, ER, Congo red, everything was negative, as we were still trying to get to another differential. Notably, going through some of the differentials, so LAM, no notable wall thinning. So negative, like I said, biomarkers for LAM. So then another one is lymphocytic interstitial pneumonia, which I think you mentioned. No lymphoid infiltrate. No Congo red, like I said. So interestingly, bird hog Dubé, so no lower lobe predilectation. So it was kind of all over, like you said, it didn't really fit with classic bird hog Dubé, which is more lower lobe predominant.
Yeah.
And no granulomas, no lymphoid tissue, so not like a hypersensitivity pneumonitis. Really.
Does she have CF, undiagnosed CF?
No, she does not have CF.
Okay.
It was tested, so no. So this case drove me nuts. I think you can see why, because everything was coming back negative. And I don't want you to beat yourself up, because to this day, even with explant data in hand, we don't have an official diagnosis for her.
What are we calling her though? Are we calling, but we have to call her something to treat her. Well, now she has a transplant, so she's in a lot of immunosuppression.
Exactly. So this lady, I'll kind of go into, if it's okay from like a timing perspective, is it okay if I tell you guys kind of what happened now? So like I said, she got more progressively dyspneic over the following weeks. She kept coming back to clinic and we kept basically telling her, we've done this test, we've done this test, it was negative, it was negative. Kind of frustrating because we were trying to get to the bottom of this. And so she ultimately was initiated on immunosuppression. So she was started with rheumatology and us on mycophenolate, hydroxychloroquine, and prednisone for maybe this is SLE with the serositis. She had many complications, unfortunately, related to her effusions, where you can imagine with the architecture of her lung, she got a pneumothorax and she had complications from the draining of these effusions that she had that did recur a couple of times. So given her rapid decline, she was seen for the transplant clinic. She went for bilateral transplant, has had no recurrence of cystic disease. We're now about 5 months out from transplant, still doing very well after transplant. But like I said, we didn't really have a clear diagnosis. And this was really frustrating with this degree of disease. And
I'm assuming her PFTs, because like now I'm very embarrassed that we did not talk about PFTs and we're both pulmonologists.
She came in through the ED, so you wouldn't have had them anyway.
Okay, but her PFTs, I'm assuming had a mixed restrictive and obstructive lung disease, lung pattern. Okay, and disproportionately reduced DLCO, I'm assuming as well.
Fairly reduced DLCO. Yep.
The reason why I'm saying that, everybody, is because the emphysema will give her the obstruction, and the honeycombing that we saw in the pure parenchymal destruction will give her the restrictive pattern, and she had no parenchyma left. So she probably had a disproportionately reduced DLCO.
Exactly. Her DLCO was like 10 or 12%. It was dramatically low. Yep.
Oh, I'm still voting for some kind of histiocytic.
Yeah.
Disease. And did we do a bone marrow biopsy?
I would have to look. I'm not sure. I imagine that probably we did. I may have missed that one. I didn't write that one down either, but right. I don't have it handy.
Yeah, I'll still bet my money in some kind of histiocytic lung disease. And I see some question popping up. Can we call this idiopathic pulmonary fibrosis? No. So we cannot. That's a very good question. Whoever asked, I couldn't see it. I just saw it popping up. So idiopathic pulmonary fibrosis, like the name says, you have to exclude everything else. So the fact that this young woman has a positive ANA and a borderline positive anti-double-stranded DNA with honeycombing automatically puts her in the ILDs that are fibrotic, but connective tissue disease related. So it has to be something else. And usually the demographics is still for pulmonary fibrosis is older man with a history of smoking. And again, you have to rule everything else. This patient had predominant emphysema. Pulmonary fibrosis, idiopathic pulmonary fibrosis is purely honeycombing, usually low predominance. This patient didn't have any low predominance for any of the findings we had on her CT. And again, like by definition, she would be connective tissue disease related ILD just because she had biomarkers that were positive for connective tissue disease. Yep. I am really annoyed. I wanna go see her biopsy.
Every day for 6 months, I may think I've thought of this patient in this case, because it's just one of those that, I mean, my learning points for this, I think that the differential for cystic and emphysematous lung disease in a young person is you get into some really cool conditions that are pretty rare, but you have to think about, because with these patients, even with these advanced diagnostics and testing that we have available, are still really challenging. And so differentiating, even when you have tissue, can still be challenging. But I think the key thing for this young woman, and I'm glad that she came in when she did, was if you have somebody that presents like this, you need early transplant eval, because she was otherwise healthy and she just fell off a cliff. She couldn't manage anymore, despite this likely being a fairly chronic process. She got in for transplant quickly and had a good outcome so far, so we're really happy about it, but a good case for referring to transplant center early.
Oh, I had so much fun. This is
Isn't that
amazing.
right?
I
Thought you'd
wanna-
like
is it okay if do we have time to go over the questions that maybe Dave and I can answer?
Oh,
So
yeah.
sorry, Dr. Sanborn and I can answer some of them. Is anyone keeping track of the questions?
Yeah,
Okay,
I
tell
was
me.
trying to find him. Here's some questions. Wait,
Yeah, welcome to Mayo Clinic.
I have a question. Can BHD cause emphysema?
Can what?
Can
Or
the
Octave?
Workup job, cause emphysema?
It's more cystic lung disease, but in the end, like advanced Berg-Hogdebay can.
Yep. And can be really hard to differentiate between the two on a CT scan.
Yeah.
Depending on the morphology.
Yeah. Lamb is very characteristic. Lamb is very, very different. The cysts in lamb are very well defined. They have like clear walls. This patient's lungs, absolute clear emphysema also. And I don't know, like I understand the pathology said upper low predominance, but like her lower lungs also had pretty bad emphysema.
Totally. It was diffuse, like you said. There was the middle area. It was kind of like top and bottom, and then that middle area of atelectasis. But I agree, it was pretty diffuse.
Yeah. And Joseph, I don't think she's going to develop symptoms because she's on heavy immunosuppression. So whatever connective tissue disease she might have is being treated by her lung immunosuppression. So I doubt that she will develop any symptoms of a connective tissue disease. However, if she has children or if she has siblings, they need to be watched.
Totally. Yep. There are siblings. And I do think that we referred them and said that they should be watched closely. Yeah. No symptoms so far.
Would it be interesting to stand for? No, that was infection, and infection was ruled out pretty early from what Dr. Sanborn said. The PCR sequencing is good for acute infections. If we don't have like a classic normal bug, then those are good for that. So if you're thinking PJP, if you're thinking histoblasto, nowadays they can be caught in PCRs. And if you're thinking like some fancy mold infections that can cause this, but usually this kind of infections, they will cause a tree in bud pattern, not lung parenchyma destruction, with the exception of PJP. The original name there is pneumocystis pneumonia is because of cysts. If people went undiagnosed for a long time, but again, it's like it has to be sick for a long time, and it would have been caught on the original both thoracentesis, like it would be in her pleural space, and also the test that was sent initially.
Yeah.
Dave, share with us how often are you following her after the transplant?
Oh yeah, so that's a really good. So once you get a transplant, this is a really good point. So transplant's a lot of work for patients, for the team taking care of the patients. So for the first 3 months after somebody gets transplanted at Mayo, they follow up at Mayo Clinic Monday through Friday, every day, Monday through Friday. Sometimes it's a quick check-in. Hey, how are you doing? Let's take a set of vitals. Things look good. You're feeling good. See you later. But they follow up every day, Monday through Friday, for the first 3 months after transplant. Just because that period, that first 3-month period after somebody leaves the hospital is so tenuous. And so you have to really watch and make sure there's no infection sneaking up. So this lady, like you guys were saying in the chat, she's on immunosuppression for life now, right? And for the rest of her life, there's going to be a balance of immunosuppression and over immunosuppressing versus not suppressing enough and getting rejection, right? And so that's the thing that we're watching really closely for. So these patients come back, they get routine biopsies to look for rejection. We're really looking for infection all the time. So follow-up is really tight.
And very important also to talk to transplant colleagues. Do you know if the size of her lungs were compatible?
Ooh, I don't know that. That's a good question. No.
So very important to ask if you ever encounter a patient who has received lung transplant. It's very important to ask or look at the surgeon's note if the size was compatible, because usually the first thing that you're going to see, actually, if the size was not compatible, is that this patient develops stenosis at the sites of airway of the trachea, anastomosis. I'm losing my words. And the tracheoanastomosis. So the first thing they're going to develop is actually more of a obstructive pattern, and more than rejection.
Mm.
Oh, that's a great question from Dr. Otayeni. I don't know how, sorry, I butchered your name. Did her pericardial effusion resolve?
Yes, ultimately, I think they called it like now tiny. It's trace. It's a fraction of what it was. Yep.
It has to be some kind of connective tissue disease that we just don't know.
I think for me, it's too much of a coincidence with this connective tissue, the serositis. I think this is some poorly understood mixed connective tissue lung disorder, that probably predisposed her to this.
Yeah, in 10 years when we come back to CP Solvers, we will have an answer for that. But
XYZ, we didn't have it back in my day.
yeah, back in my day, we were stunned. See, you did stun me. What was the thing? What was the name of the thing you did in residency?
It was called Stump the Chump.
Stump the Chump. Yeah, you did.
I just thought, you know what, sometimes we don't always know the answer, but it's the thought process that gets you there, the workup that is important. And so you went through all the differentials, and I think that had a really targeted approach, but even still, sometimes you still struggle.
Yeah, and that's okay.
Yep.
That's okay. There's no growth without a struggle. What other questions that we didn't answer from the listeners?
There's another question from Emma that I think was answered. Would be interesting send for respiratory disease next generation sequencing panel. I think we answered that, her siblings, and would have to continue.
Yeah, but again, this is not infectious. So the rapid sequencing is more for infectious processes. Dave, there was a question that popped up that was pretty awesome. Do you want to answer that one?
Yeah, is it possible for the transplanted lung to become compromised even if the underlying cause of the original injury is still present and undiagnosed? You bet it can. And so this is definitely something that it makes you uneasy, right? Because you know what you have to do in this case, and you offer lung transplant because there's really not a lot of other options. And so, I mean, otherwise going on like prolonged ECMO, which is not really, that's a bridge to a treatment. And so the treatment is transplant. And so absolutely. So she is somebody who you feel much more comfortable in the transplant world when you know what you're treating, you know what you're transplanting. We don't know. So I think for a while to come, she'll need screening just to make sure no cystic changes, no emphysematous changes are happening.
Yeah.
And we had one. Oh, sorry, Dr.
No, go ahead.
We had one more question. Like in these 3 months that the patient go every day for the Mayo Clinic to check, there is any type of infection that can affect more the patient, or anything can be like can make a bad prognosis about the lung transplant in that gap of time?
You mean like what infections are transplant patients at risk for?
Yeah.
Is that a fair? So you know what, to be honest, any of them. And I'll be honest, the answer to that is when people with transplants have infection, still the thing you may have heard is common things are common. So the common bugs still affect people with transplants. So we're talking like strep pneumo, the typical bugs that cause community acquired pneumonia. Those are still the number one thing. But what I will add is that they are prone to developing the ones that sometimes you see and you're like, well, I don't know if that's causing a problem, or you know, these people end up in the hospital a lot too, so they're exposed to healthcare environment all the time. So Pseudomonas, very often you see Pseudomonas on these washings that you do to follow up transplant patients. Weird fungal things. So you do start to see the weird fungal stuff start to pop up. So Aspergillus, all of these other weird fungal type things, and they are prone to anything. So you always have to watch. Now, some people get colonized with this stuff, but they feel fine. They have no symptoms of infection. They don't look infected. They don't have pneumonia. They just find it on a wash. So then the question is even harder. you have these bugs growing, but they feel okay. Do you treat it? Right. So there's always this long-term communication with the transplant team and following up with pulmonary to know when to treat and when not to treat.
Yeah, that was a very good question. That was a very good question about location of cystic lesions. So the location of lung lesions are actually very helpful for us to narrow our differentials regardless of the type of lesion. So for cystic lesions, for example, for lamb, like I said before, very small, hundreds to thousands, diffuse. Bird hog debate usually is hundreds, lower lobe. Amyloid, for example, usually it's going to be this kind of like vascular distribution because amyloid. If it's a lymphoma, believe it or not, can cause cystic lung lesions. If it's a lymphoma, it's going to be around lymphatics. If it's a sarcoma, for example, super rare, but you can have sarcomas in the lungs. They usually come with like a big cystic lesion, and it's usually alone.
Yep.
Same thing, Dave. And if you want to talk about this, you just shut me up. But same thing with emphysema. Upper lobe predominant emphysema is usually related to inhalation. So smoking, like I mentioned before, wood burning stove and fireplaces if they don't smoke, vaping and things like that. Very important. I forgot to say, smoked marijuana usually causes cystic lung lesions. So very important to know that too. It's not as much as emphysema, is more cystic lung lesions. And again, emphysema means a destruction of the parenchyma. Cysts mean very well circumscribed lesions. They are usually not related to vessels or lymphatics, depending of what they're being caused by. And the same thing with honeycombing. Again, honeycombing are tiny cysts, thick wall cysts that usually are going to come in lines. That's not what rows. I'm sorry. They're going to have rows, 3 to 4 rows, and depending on where they are, we narrow our diagnosis as well. If it's pure honeycombing, lower lobe predominance, we start thinking about idiopathic pulmonary fibrosis and or short telomere syndrome. If they are more upper lobe predominant, we start thinking about fibrotic connective tissue disease related lung disease. So yes, the winded answer to the question of like the location of lung lesions does matter for diagnosis.
Yeah, thank you so much, Dr. Gallo and Dr. Sanborn. It was a really interesting case. I was like, oh my God, what will be the diagnosis? And Dr. Gallo, if you have one teaching point that you take away with you with this case, and Dr. Sanborn too, that want to share with us?
Yeah. You know what? My teaching point for this is always cast a wide net and take the time to invest in the differential, which is why I'm so glad you guys do these things, because this is the patient that really needs that wide differential, and you need to start broad in the beginning. And I think this is just such a good example of that. So as you guys go on in your career, that's my #1 learning point, and that's what makes you a really good physician, is to cast a wide net and see what comes back.
What Dr. Sanborn said.
Thank you so much. Bettina did there's our teaching points. We can see that you take a really good one.
Yeah.
If you want to share with us, please.
Yes, wow, that is such an amazing case. It was so exciting. I felt the exciting energy in the room. So we have a lot of teaching points. I've learned so much about this case, even if we don't have a definitive diagnosis. So let's jump right to it. So first, when we were talking about the history, we explored the different possible symptoms in our patient. So first, for dyspnea, other things that we can look for is associated symptoms like cough, weakness, weight loss, fever, night sweats, chest pain, and rashes. We can also look at if the dyspnea was at rest or if the dyspnea was with exertion. And of course, we look at tobacco or vape use. And then for cough, we can check for the time of day when it was more predominant, because some differentials like postnasal drainage can usually happen at night. And then usually cough related to airway occurs with exertion. And we also have to remember that not everything that causes dyspnea comes from the lungs. So there are a lot of different etiologies that can be associated with dyspnea. So a lot of things that we can explore still in the history is, for example, the impact of the disease to the patient. So before the disease happened, what was she able to do? And then what is she able to do now? And then we also ask for travel history because we look at different endemic diseases depending on where she went to or where she is living right now. We also ask for pets because dogs can sometimes give humans blastomycosis, and there are a lot of other diseases that pets can give. We can also ask for the pregnancy status because there's what we call the dyspnea of pregnancy, which can be physiologic in a patient with who is pregnant. And then we ask for episodes of snoring or sleep disturbances because untreated sleep apnea can cause daytime dyspnea. And then we also look for medications like steroids and beta blockers, which can sometimes lead to dyspnea, family history of lung diseases, autoimmune diseases, and thyroid diseases, history of trauma, joint complaints, or any signs of vasculitis that can point us to serositis or connective tissue diseases, exposure to wood burning, which can cause emphysema in non-smokers. And in this young patient with dry cough and weight loss, we would usually think of cancer, fungal infections, atypical mycobacteria, tuberculosis, anemia, or any bone marrow disease. And then for hypoxemia, there are a lot of different causes for hypoxemia, but a prominent one in our patient, which was pleural effusion. This one can make a patient hypoxic, and it can be parenchymal disease, malignancy, a slow-growing infection, or a heart disease. So that's why we also check for EKGs and echo. And then we also check for hypoxemia sitting down versus sitting up, which can help us check for pulmonary hypertension as well. And then our patient also had pleural effusion, and it is important to also check for the appearance of the fluid, whether it is clear, it is turbid, and check with Light's criteria, if it is exudative or transudative. And then we also try to rule out tuberculosis by using acid fast and PCR. So if a patient presents with effusion and you will think you need a chest CT, it is important to tap the effusions beforehand so that we can see the parenchyma open. If it's a small cancer, it can be in an atelectatic lung under the effusion. And then we also talked about that if in a young patient with pulmonary fibrosis, we can also consider short telomere syndrome. And then in the chest CT, there are a lot of findings that can also lead to a lot of differentials. So for example, our patient had honeycombing, which is small cysts, and emphysema, which is trabeculations and usually without cysts. And locations of the lesions matter in the diagnosis. So for cystic lesions, some differentials would be LAM, which could show hundreds to thousands of cysts all over the lung. And then lymphoma can also cause cystic lung lesions around the lymphatics. Sarcomas in the lung can have big cystic lesions that are usually solitary. And smoked marijuana can also cause cystic lung lesions. And then when we talk about honeycombing, they usually have 3 to 4 rows, and usually upper lobe, usually fibrotic. We think of connective tissue lung disease. And now for emphysema, there are a lot of things that